ED is a 21-year-old female newly established patient who presents today for nausea and vomiting, for depression, and for preconception counseling. She reported to the ED on the 23rd for nausea, vomiting, and diarrhea. She hadn't been able to eat or keep anything down for 3 days and decided she needed to go to the hospital. She was treated with IV fluids, and she was discharged with a prescription for Zofran 4 milligrams POQ 8 hours PRN for nausea and vomiting. She notes that she wakes up every morning since discharge feeling nauseous and feeling like she needs to vomit, but she does not actively vomit or have diarrhea. She takes the Zofran once a day when she wakes, and that's the only dose she takes. She does keep crackers by her bed just to have something to put in her stomach when she wakes up to alleviate some of the nausea, and that seems to be working. There was a pregnancy test performed at the ED, and that was negative. She also has a history of depression and anxiety, and she was seen in our office by a different provider 2 weeks ago and was prescribed fluoxetine 10 milligrams. Since she started that, she started having headaches about 3 to 4 days after starting the new medication that she says lasts a few hours. She gets 1 to 2 of them a day. They focus here in between her eyes, but then it's diffused throughout her head. She waits as long as she can to take anything for it, and when she does, she takes 2 baby aspirin and notes that she gets good effect with that. She reports feeling anxious the past 4 days. Her heart races. She feels nervous. She feels like something bad is going to happen. And she notes that her sleep pattern has changed since she started taking the fluoxetine. She used to sleep 12 hours a day. Now she's getting 6 to 7 hours. She also notes that she's waking up with the nausea, so that nausea is actually waking her up, so that could be also disturbing her sleep pattern. She endorses a great deal of stress right now. Her boyfriend of 4 years was supposed to deploy. He's in the Army. He was supposed to leave on the 24th. That did not happen, and I'll get to that in the social history a little bit. She would like to move. She lives in a neighborhood that is not so safe, and I'll get to that in the history as well, but this is contributing to the anxiety and the depression. She endorses a history of cutting as a way to deal with her depression and her anxiety. She notes occasional SI, but not today at presentation. When questioned about having a plan, when she does have these thoughts, she endorses that she's had a plan in the past. She does not have a plan currently that she would put into place, and there are no weapons, no guns or any other weapons in her home at the time. She denies HI, but again, she has had a history of self-harm in the last year. The details were not provided to us in this visit. We discussed with her that if she is having a crisis, she can call our behavioral health crisis line. She can call this office 24 hours a day, or she can report to the ED or call 911 and tell them that she's in crisis. So we talked about that quite a bit. And finally, we did some preconception counseling for her. She is actively trying to get pregnant. She's a G1P0 with a history of spontaneous abortion at 8 weeks gestation. Her last menstrual period was 10-10. She's not taking any contraception at this time to prevent pregnancy. She's been on Nexplanon and Depo-Provera in the past. She was recently on some oral contraception, and she discontinued that use in April. Her past medical history is significant in that she has a history of depression, the spontaneous abortion at 8 weeks gestation, and she had childhood asthma. Her hospitalization history is insignificant. Her surgical history is unknown. Her family history is significant. That there's a history of depression on her paternal side. The specifics of which relative it is was not given at this visit. Her social history, again, as I mentioned before, is significant in that her boyfriend that she lives with of 4 years is supposed to be deploying into the Army. If he was supposed to leave on October 24th, if you remember what I said at the beginning, she reported to the emergency room on the 23rd with this anxiety, the nausea, vomiting, and diarrhea. But he did not deploy. He will be deploying in 6 months. So this is still a cause for concern and a source of stress for her. He is a significant social and emotional support for her, especially with the depression and the anxiety that she's had for quite some time. Again, her living situation is not what she calls safe. There have been 2 incidents in the past week where her car was broken into, her car was hit, and the person left the scene. She just doesn't feel safe in her neighborhood. She's trying to move, and that is a source of stress. Again, she is also working about 8 hours a day, 4 to 5 days a week, which is an increase for her because a coworker of hers passed away, and he and his wife both worked with her, so they're down staff, and that means she's working more. So the death and the excess hours, um, she's just feeling a lot of that stress right now. So her review of systems was pretty, aside from the HPI, there was no fever, chills, or excess fatigue. She had no chest palpitations at presentation, no shortness of breath. Again, there are the GI symptoms and what I didn't discuss earlier that she noted when we were going through her review of systems is that she experiences what she's calling sensory overload, that if she's exposed to too much visual or auditory input, she gets really sensitive to both and is unable to handle it and has to remove herself from the situation. There are no headaches associated with this. It doesn't seem to be prodromal for a migraine. This is so weird looking at myself in a video. I'm sorry, guys. And her physical exam was, we didn't do much for her physical exam just because we focused so much on the depression and anxiety in this visit, but because of the nausea and vomiting, we did an abdominal exam, and there was, her abdomen is soft. She had normal active bowel sounds in all 4 quadrants. There were no masses. There was no tenderness to palpation, either light or deep, and there was no guarding. Also, she did not exhibit any signs of mania or dysphoria or any incongruence with her affect and her reported mood. There were no labs done, and this is my patient.